My name is Shaun McCann. I'm conducting expert interviews on behalf of the European Hematology Association at the annual meeting of the American Society of Hematology, which this year is in Orlando in Florida. And with me I have Mary-Frances McCullin. You're very welcome. Thank you for coming along. And Mary-Frances is Clinical Professor, School of Medicine and Dentistry and Biochemical Sciences, Centre for Cancer Research and Cell Biology, Queen's University, Belfast.
Yeah.
Which is...
That's not actually quite right. Do you want this? Does it matter?
We can fix it later. Yeah. And she is an expert on erythrocytosis, so we're going to spend the next 10 or 15 minutes talking about that. So I suppose to open the batting, how do you make the diagnosis?
Well, somebody gets a full blood count and it is judged to be above the normal range. And of course, that is the first problem, as you will be only too well aware, because the WHO criteria for polycythemia vera now quote numbers which are actually in the normal range. However, these patients certainly get referred because of a blood count above normal. However, to make an erythrocytosis is actually, by definition, a red cell mass greater than 125% are predicted for against control for body mass and sex. That is what it actually means. It correlates, the greater than 125% correlates quite well if the hematocrit, better than the hemoglobin, is particularly high, above 0.6 in a man and 0.56 in a woman. It's always is the same as greater than 125%. But there's certainly an issue with numbers below that. Do they really have an erythrocytosis or not? And of course, you know what I'm going to say next. If you want to prove the point, you need a red cell mass.
Who does that now?
Well, that's quite... some people still do it, and it's going to come back to some extent. The problem is that the chromium has all been withdrawn, but the nuclear medicine departments are, certainly in the UK, are looking at doing it with technesium. As Oxford and Guy's, I think, have already got it going. Our people tell us they'll do it when they've got enough staff. But it is, I mean, it has been an issue for a long time, and it's still an issue. And as I say, it doesn't matter when the hemoglobin's very high, but I've certainly had patients in my clinic referred with a supposed erythrocytosis. When you do the red cell mass, it's normal, or it's in the normal range, and they're probably just a bit dehydrated.
Right. So it may come back into fashion again then.
I don't think it'll come out sort of to prime time, but it's a useful investigation. Yes, you're going to do the JAK2 and get around the clonal ones that way, but it's a sort of grip at the end, actually looking to see have their erythrocytosis.
Right. Now, as far as I understand it, there are two major categories, apart from the myeloproliferative diseases, the congenital ones and the sort of idiopathic ones.
Well, you can.
Am I?
Well, you can actually take the classification broader than that. So you'd start off with primary or secondary.
Okay.
So primary is with a low or sometimes normal, but low normal erythropoietin level, and in that case you'd be looking at a defect intrinsic to the erythroid compartment. And then secondary, where the EPO is normal or elevated. Elevated obviously makes sense. Normal is actually also shows you have an EPO drive, because having a normal EPO level in somebody whose hemoglobin is 200 is not actually normal. So we have often referred to that as inappropriately normal.
Right.
So that's primary or secondary first. And secondary then it's erythropoietin driven. You can then classify it much further, starting with the primary into congenital or acquired, the main primary acquired disorder being polycythemia vera. And similarly with the secondary, congenital, and I get to talk always about a list of rare congenital causes, but actually, of course, the majority of the secondaries are acquired, and you can classify that down starting with central hypoxia, local hypoxia, pathological EPO production, taking of substances that put the EPO level up. So you can produce a long list of acquired causes, and then you're left with a group where you can't find the cause, and that's what falls into the idiopathic category. And of course, it's both primary and secondary, because it's the ones that you haven't found out what's going on.
Are there any clinical indications that separate one group from the other? I mean, or do you have to rely on laboratory tests?
You have to rely on laboratory tests. Well, actually, I would say the first thing you have to do is take a history from and examine the patient and repeat the full blood count before you go any further than that. You know, you want to get, we've all had the blue bloater that's probably not the correct term nowadays, but
we're not
you know,
PC.
referred because their hemoglobin's up, you know, as they put their cigarette out as they come into the hospital. So, you know, a lot of those can be screened out just by taking a good history and having a look at the patient rather than reacting to a blood count.
So history is still important.
It's my book, very important.
That's good to hear, Barbara.
And the blood film.
I was going to ask you, that's my next question. Do you still have a microscope?
Well, I do, yes. And I think it's always worth looking at a blood film in a new patient. It's not going to get you much further if we're talking about erythrocytosis. It is useful to get, you know, that they're not really a myelofibrosis or something like that. But it's not, you know, it's not going to tell you anything along this.
So EPO levels obviously are standard now.
EPO levels are standard, yes.
Okay. Oxygen dissociation curves, who does those?
Very few. We used to do them for years. In fact, I think you sent samples up on the train and then the machine broke and nobody could pay for the parts to get it fixed. So that is a problem. I think King's were doing them at one stage, but then you've got to get the sample and the control there. And all of these laboratory tests have an issue with quality control.
Yeah.
So the list of investigations you should do will have an oxygen dissociation curve. And the likes of you and I did many of them in the past, but you've got to actually find somebody to do it. So when we get to the next generation sequencing, I will give you a suggestion as to how you get around that.
But what do you do practically at the moment? What do you do? As I say, in the real world.
We would do, if you're thinking, because on oxygen dissociation curve, you're looking for a high affinity hemoglobin. And certainly our next generation sequencing panel has the hemoglobin genes on it deliberately.
Right.
So the next test you would have had was hemoglobin electrophoresis,
yes.
which isn't that much use with the high affinity oxygens, although you would do it. But you can really say, and this is what people were actually doing, that you can skip and go to sequence looking at the hemoglobin genes. And people were doing that because it was easier actually to do the molecular analysis of the hemoglobin genes than get the P50 and the hemoglobin electrophoresis. And that's why when we put up a custom design panel to try and cover all the congenital causes, we put the hemoglobin genes on it as well. Right. Because actually the ones that over the years most frequently missed causes of erythrocytosis are the high affinity hemoglobins.
So, I mean, in terms of prevalence or frequency, I mean,
these are rare disorders.
Would you see 1 a year, 2 a year, 10 a year, or?
1 a year, but depends on who's looking and what, you know. I've just stood up yesterday and 10 people wanted to know, how do you do this panel, because I have these patients and I can't I can't look for these things.
Okay.
I mean, it takes you back to the idiopathic erythrocytosis, which is those you can't find it. When I did this talk at ASH 10 years ago, it was actually titled Idiopathic Erythrocytosis, a Disappearing Entity.
Okay.
And the idea was at that point we had just found the HIF2 and the VH, I'm not sure if we even got the PhD2 and the VHL, and here we're finding some causes for this congenital erythrocytosis, and lo and behold, if you could look at them all, you were bound to find it. So there's less like that, but even with what was really probably the biggest study which we were involved in with Carney Campus as the first author, where everybody threw all their erythrocytosis samples into, it was part of the whole genome sequencing project, and they were looked at with a really extensive panel, and we found lots of interesting things, but 54% of them had no genetic variants.
Right. And of the genetic variants, just to explain again the sort of more common ones.
Okay, so again, you do this primary secondary divide. So primary congenital erythrocytosis common is not the word I would use to
Well,
describe
frequent.
it, but the one that is found with a low EPO is the EPO receptor mutations, and there've been a series of those described, and possibly a few more, but they are really very rare.
Right.
Link is much rarer, but there have been some congenital link mutations, which would be a primary defect, but they're vanishingly rare. The majority of these things are secondary congenital erythrocytosis. So in the oxygen sensing pathway, you have mutations of VHL, most famous being the homozygote VHL Chuvash mutation.
Right.
Then heterozygous mutations of HIF2 alpha and PHD2. The other sort of new kid on the block, for want of a better word, is that Radek Skoda's group have done very elegant work describing a gain of function mutation in the erythropoietin gene itself. So, but this is a gain of function mutation, so it actually ends up with increased erythropoietin and then erythrocytosis. Then you have the high oxygen affinity hemoglobins, which I suspect overall are much more common than all the rest of these, because people knew about those, and one, they're overlooked, and two, there's far more of them out there. But once people diagnose it, they don't think of them in the same category, but they are. And then you're onto the very rare things, the BP bisphosphoglyceride mutase, and there's a few very rare things that
we refer these to you, definitely. Okay, we'll finish up on talking about treatment. I mean, when I was young, about 1,000 years ago, venesection and aspirin.
Yeah.
Has anything happened since?
No, well, first of all, you need to remember that these are congenital disorders, and it's always very important. Well, the defects that I've described are congenital disorders. Idiopathic erythrocytosis we'll come back to in a minute. So they're germline disorders. They're not acquired neoplastic disorders. There is very little evidence out there as to what to do to treat them. There are some things in the literature, some fairly horrific stories of people having thrombotic events with some of these. And
after venesection, you mean?
No,
without it.
And there's even a suggestion, but it's very hard to get more work on this, that these people, what happens to these people over time. There's some cases describing them getting pulmonary hypertension. So what can you advise for management? Everybody gives them aspirin, low dose aspirin. It works in PV. First, do no harm as long as they're not bleeding from their ulcer.
Yes.
There's actually little evidence that it makes any difference, and in fact, in the retrospective Chuvash studies that Joe Burkall's group did, it didn't show any benefit at all. Venesection then comes up, and the temptation is when we treat PV is to reach for the venesection. But there may well be a reason for not to do that, because many of these things effectively end up with abnormal physiology. So like the oxygen dissociation curve. So, the patient physiologically may need higher hemoglobin or hematocrit to function. And in fact, there was nice studies done in Oxford where some of these patients were looked at in physiology, and their body set like they were up the top of a mountain. So you don't want to venesect them down.
Drag them down.
So all you can suggest is that you might wish to do a little gentle venesection if you think they have symptoms that are related to their hematocrit. And in the high affinity oxygen, there is, because they're usually autosomal dominant inheritance, there is evidence to suggest that if you have somebody who has with a high oxygen affinity hemoglobin, who's had a thrombotic event and then been venesected, other family members should get venesected before they get to having the thrombotic event. Okay. And then you get to what level you should go to. And when we wrote the guidelines, we were very careful not to put numbers on it, but you're sort of suggesting 0.55, that sort of thing, but certainly not anywhere near 0.45. Right. That all came from PV and nowhere else.
Well, thank you very much. We'll just finish up on guidelines, because I have a thing about guidelines. How long are your guidelines?
Well,
how many pages?
our guidelines are very good. The polycythemia vera guidelines. We won the British Journal of Haematology Guideline of the Year. So what we did, they are evidence-based guidelines. And we did an extensive literature search and then did all the papers from 2005 and then incorporated that in. I did not do it all myself, but we had various people did various groups. And then each group had to take their advice to the whole group. So it was all agreed. They can't be more than 5,000 words. That's why they're split into two, because we did PV and then the special situations. And they have the guidance as bullet points at regular intervals. That's the way the BSH makes you do it, and it's actually very efficient.
Because I have to hold my hand up, and I was a co-author on a 20-page guidelines, which is
but it has
a chapter in a book, and
it
not
has
guidelines.
to be. And I've been part of many European ones that everybody gives their opinion.
Yes,
they are long because they cover a lot. I mean, we do the diagnostic criteria the whole way through, but as I said, the BSH method is very, very keen that you put the guidance with the levels of evidence as bullet points everywhere you go along. So you could, and I usually do this when people ask me, I mean, you could go in and just lift the bits, the 3 or 4 points for that particular question.
But as I said to a number of people in the last day or two, unfortunately, the judiciary think guidelines are rules.
Yes, but there's actually a disclaimer on that says that's specific. All of them that says that's specific. This is guidance.
I know, but nobody ever reads that.
It's not actually just the judiciary. If you see what happened in Shaun, it's quite interesting, where guidelines go out and then they go into the organisations and get taken as thou must.
Yeah. Okay, on that sort of controversial note, thank you very much indeed for sharing your thoughts. So for you young investigators, there are still, I'm sure, new things to be discovered in erythrocytosis, and hopefully we'll have a new acceptable test for measuring red cell mass in the near future. Thank you.